So hello and welcome to the Spinal Cord Injury Forum. I am Stephen Burns, Medical Co-Director of the Northwest Regional Spinal Cord Injury System. The forums, the video recordings, and our online media content are made possible by a grant from the National Institute on Disability and Rehabilitation Research. Tonight we are pleased to have two speakers presenting on aging with a spinal cord injury. Dr. Rina Reyes, Medical Director of the UW-Medicine SCI Rehabilitation Program and Assistant Professor in the UW Department of Rehabilitation Medicine, and Ivan Molton, Clinical Psychologist and Acting Assistant Professor, UW Department of Rehabilitation Medicine. Please welcome Dr. Rina Reyes.
Today, if you came to this forum hoping that there are answers to the questions on how to age or prevent aging and the impact of aging, you might leave somewhat disappointed. What I hope to do is not give you any specific answer, but to really give you some information that will help you not only live your life as best as you can, but to live your life as long as you can. So with that, we'll get started. So we are a culture that has always been very preoccupied with the issue of longevity. And this stems from days of Ponce de Leon, who was a famous explorer who was trying to find the fountain of youth. And had he probably not succumbed to the results of a gunshot wound to his thigh at age 60, he might have actually come up with something that all of us would have found useful. But even in the contemporary times, we have movies, media, there's a lot of literature related to the issue of aging, but also aging well. How many of you have heard of the book The Blue Zones? Anyone? So no one's an Oprah watcher or a National Geographic reader. But The Blue Zones is a book that's dedicated to evaluating themes in longevity in cultures that have the highest proportion of centenarians in their population. And so they have very interesting learning lessons from that as well. So today we're going to talk about what normal or usual aging is, but also theories regarding the aging process, the physical and psychosocial aspects of aging that's specifically related to spinal cord injury, and then recommendations for mitigating or minimizing the impact of aging. Today we'll have Dr. Ivan Molton helping me with discussing the psychosocial aspects of aging, since that's in his area of expertise. For the therapists in the audience, here are your goals and objectives. And really is to discuss the expected organ system changes, the theories of aging, identifying the unique medical and psychosocial aspects of aging on persons with spinal cord injury, defining components of preventative care, recommendations for maintaining health and wellness over the lifespan, and listing exercise goals, recommendations, considerations, and strategies. So to start talking about aging with spinal cord injury, we have to take a step back and talk about what normal or usual aging is. And so we all really begin aging from the time that we're born, right? Every second that I'm standing here, I'm aging in front of you. And we all have an expected biological or physiologic decline that ultimately results in reduction in our physical capacity. All of this requires a constant change and adaptation in our lifestyle. Over the past few decades, we know that life expectancy in the general population has increased significantly. This is particularly true for women who have continued to basically outlive men in their survival. Currently, there are estimated to be 4 million Americans who are over or at least the age of 85, with an estimated 5-fold projected increase by the year 2050. So this will be a significant part of healthcare in general. So let's talk about epidemiology of traumatic spinal cord injuries in particular. As of 2008, there are about 259,000 Americans who are currently living with traumatic spinal cord injury. And the trend has been towards an increase in this number from year to year, primarily attributed to improvement in life expectancy. The average age of injury has also increased from 28.7 several decades ago to, looking at data since 2005, now up to 40.2. And there are many reasons for why we think this is the case. There's also an increased incidence in particular for traumatic spinal cord injuries to be occurring in those of older age. When we look at survival rates after spinal cord injury, there's been quite a vast improvement over the last few centuries, certainly. This picture is one of my favorites. It's of an Egyptian physician named Imhotep, who actually described what we believe is provided the first written account for an individual who sustained a traumatic spinal cord injury many, many centuries ago. And in his description on a papyrus sheet, he actually described this as a condition that should not be treated, because ultimately this person went on to succumb to the injury several hours to days later. Since then, survival has improved significantly, and as of 1998, which is now 11 years ago, those with complete tetraplegia or quadriplegia have estimated life expectancies of 70% of the general population, while those with complete paraplegia, 86% of the general population. And anyone who is an impairment scale of D, meaning that there's quite a bit of motor preservation, now estimates are about 92% of the general population. So as life expectancy improves after spinal cord injury, this really highlights many of the usual processes and diseases associated with aging. As people are living longer, they are beginning to experience many of the diseases that the general population is beginning to experience as they age. In addition to that, there's an increasing incidence of spinal cord injury among those who are greater than 60. And as of 1995, about 40% of those who are greater than 45 years old were 40% of those living with spinal cord injury are over the age of 45, and a quarter of the population was more than 20 years post-injury. A British study performed in 1993, or conducted in 1993, indicated that the average age at which assistance additionally was required was about 49 if you had tetraplegia or quadriplegia, and 54 if you had paraplegia or paraparesis. It's difficult to compare that because of the healthcare systems being slightly different between the United States and Great Britain. So the aging concerns in those with spinal cord injury are really to minimize the impact of aging by improving awareness, by being vigilant about surveillance for disease processes, and by preventing complications from this disease. So the goal is ultimately to maintain overall health, maintain your independence, and also to maintain a certain level of life satisfaction. There are great debates about what causes greater disability with the aging process among those who are already disabled. And Pentland is known for coining the phrase double jeopardy or doubly disadvantaged when he talks about those with existing disabilities aging and suffering the consequences of aging possibly prematurely. There are also discussions about age being a leveler in the sense that those who are not disabled may not be used to how to adapt their life constantly in the way that those with disabilities are. And so as they reach an older age, they struggle more with adapting their lives to a new disability and functional change. People have also used the phrase the tipping point, in that we believe that we all have internal physiologic resources that we have that help us adapt to different changes with age, and that this may already be stretched to the limits among those with disabilities, and the increased demand of aging sort of tips the balance in favor of greater functional decline. People have also theorized that there are accelerated aging effects among those with spinal cord injuries and other disabilities. Regardless of what theory of aging we believe, whether it's the loss of adaptability, the loss of our ability to correct defects as they arise in the course of natural life, we believe that there are likely many, many factors that affect aging and our experience of aging. The exact mechanism is really unknown, and we know that genetics certainly has a lot to do with it as well. We do know that there are changing views with regard to aging, and we hear that all the time when people say, 40's the new 30 or 50's the new 40. Even though it can be really annoying to hear that, there probably is some grain of truth to that. That there are people who really want to live their life with greater vitality than they did in the past decade. In addition to that, there are many dimensions to aging. We're going to hear about physiologic effects. We're going to hear about psychosocial effects. And they're not necessarily commensurate with each other, meaning that we can have biologic decline progressing, and yet hopefully we're all getting psychologically, psychosocially smarter, that we're all gaining more wisdom even as our body might not quite be functioning at its capacity. The NIH has a branch of government dedicated to aging and aging research called the National Institute of Aging, which really has some very good resources online. And what they do is investigate ways to not only live longer, but to support healthy aging, with the goal being active life expectancy. The conclusions from their often quoted Baltimore longitudinal study of aging is that there's no single chronological timetable that exists for everyone. We all age in different ways and at different rates. And ultimately, aging is tied to the issue of health, maintenance, and wellness. So when we talk about health, maintenance, and wellness, we're really trying to define what preventive care is. And in general terms, there are two types of preventive care. First is primary care, which is really freedom from preventable disease. An example of this would be an intervention where you encourage people to get immunized against a disease such as influenza, and that prevents the disease from ever occurring in the first place. Really, we live in this sort of second sphere of secondary preventive care, which is early detection of disease that may not otherwise be preventable, at least at this stage in our medical history. The goal is really to prevent morbidity and mortality via screening for modifiable risk factors and early evidence of disease that we could otherwise treat. And we accomplish that through a series of periodic health examinations. So health promotion campaigns, such as you will see primary care physicians utilize, really take the form of risk modification assessment by looking at lifestyle choices, behavior choices, and making recommendations regarding wellness activities. And there are a variety of different guidelines, both in the United States and Canada, that are available. The general components of a health promotion program would include regular exercise, weight management, a balanced diet, abstinence from tobacco, alcohol, and recreational drug use, stress management, safe sex, abuse prevention, protecting personal safety, and immunization status. The dilemma that we have, however, as spinal cord injury providers is that there's no single comprehensive clinical practice guideline that addresses issues related to preventive health in spinal cord injury. There are clinical practice guidelines that exist according to organ systems, but there's not sort of one document that we all universally follow to the same degree. This is in spite of the fact that we know that healthcare affects individuals with a disability in a very different way. We know that there are unique healthcare needs such that there's a narrower margin of health. There are greater disparities in opportunities for preventive care. There's individuals with disability at a higher risk for and have earlier onset of certain chronic health conditions, and that these new health conditions can actually be associated with secondary functional losses or functional decline. And treatment may actually be more complex and prolonged in individuals with disability than those who do not have disability. And finally, in the course of treatment for these acute conditions, there may be the need for new equipment or other assistive technology. So we know from research that individuals with disabilities are less likely to receive preventive care services and screening, and that they're less likely to have exercise and have dietary control. The tendency, however, even among healthcare providers like myself, is that we are just as guilty as many other providers at focusing on crisis management during the visits. That is, with the pressures to get patients in and out, to see as many patients as we can, we often neglect to ask about healthcare maintenance issues and focus really on what the problem is that you're presenting with in clinic. The spinal cord injury, even though there is a single event that may produce the spinal injury, we know that this is not ultimately a static condition, as is any disability of any kind, because there are effects related to aging. Spinal cord injury is usually found to be a life of constant adaptation and can result in functional decline and new needs, as we discussed earlier. So aging is accelerated in the setting of spinal cord injury, and the effects of aging can be more apparent because of the cumulative stresses acquired in the process of learning to adapt to spinal cord injury. So what do we know? I mean, there's a lot that we don't know about the aging process in general, but what we do know is this, that even among those who do not have spinal cord injury, there's a constellation of 3 symptoms that we know generally heralds the onset of functional decline or the need for more functional assistance. And this includes fatigue that's unrelated to activity and for which there's no identifiable medical cause, the onset of new pain, and new weakness. If you see these three symptoms together, then likely this will be associated with some functional decline. And we know that this occurs earlier in those with spinal cord injury. So this slide actually comes from Dr. Burns, and he put this together with a distribution bar graph looking at survival and causes of death for those in the general U.S. population and those with spinal cord injury. And I believe he took CDC data to look at the general population's cause of death and looked at what has been reported in spinal cord injury. What you can easily see is that those with spinal cord injury are at greater risk for death related to respiratory complications, from bloodborne infections or sepsis, and from complications related to kidney disease. This is reflected as well in other studies that were conducted by Frankel over his 50-year career following individuals with spinal cord injury, which documented primarily respiratory disease, diseases of the urinary system, and heart disease as the three primary causes of death. What else do we know in terms of what conditions might be expected at some point as people age with spinal cord injury? There is a research conducted within the VA system among veterans who have spinal cord injuries and looked at the prevalence or occurrence of certain disease conditions at a single point in time. And what that revealed is that there's a higher incidence of certain conditions such as high blood pressure, cholesterol disorders, diabetes, overweight issues, and infections primarily due to pneumonia, urinary tract infections, and complications from pressure sores. There is also found to be an increased incidence of bladder cancer in the population. So we're going to use this information to discuss by organ system what you can expect from general aging effects, what we can expect in particular in the setting of spinal cord injury, and what recommendations and considerations we have to mitigate the effects of aging. So starting with the cardiovascular system. In the general population, this is still singularly the highest cause of death in the general population, with the risk factors being age, atherosclerotic disease, and lipid dysfunction, inactivity, glucose intolerance or diabetes, tobacco use, and high blood pressure. Even though a recent review revealed that spinal cord injury is not an independent or direct risk factor to produce coronary artery disease, we know that spinal cord injury is one at times more difficult to diagnose in the setting of lack of sensory symptoms, but also we know that there are certain conditions that are felt to be atherogenic, meaning that they can precipitate or be contributing factors to the onset of coronary artery disease that occur at a higher rate in the spinal cord injured population than the general population. And we mentioned some of those factors earlier. So lipid disorders, diabetes, obesity, lack of physical activity, early changes in body composition that result in higher body fat per unit body mass, and occasionally high blood pressure. And all of these result ultimately in a higher risk for premature heart disease. Heart disease and spinal cord injury is quickly becoming one of the leading causes of death, and certain studies have revealed that this is a contributing factor to as much as 22.4% of deaths among those with spinal cord injury, and that the mortality for any single cardiovascular event can be more than twice that of the general population. Lipid disorders are also more predominant, as we mentioned earlier. In particular, HDL, or the good cholesterol, which is usually elevated by exercise, is lower. There's a higher incidence of low HDL in those with spinal cord injury, particularly those who have higher levels of injury. There's also a higher incidence among those with higher levels of injury of diabetes or glucose intolerance. What was really concerning is that studies on the VA population suggested that those who did have diabetes, that among those who did have diabetes, 25% already had reported eye involvement from their diabetes, and 41% had foot ulcers requiring more than 4 weeks of healing time. So if you are diabetic and you have a spinal cord injury, it really merits much closer follow-up from your primary care physician than the general population would require. Other cardiovascular risk factors that might be associated are obesity or overweight syndrome, and this results primarily because of atrophy of metabolically active skeletal muscle and the inability to exercise to capacity. This results, the increase in fat per unit body mass, we believe, results in what we think is an overestimation of what the resting metabolic rate is for individuals who have paralysis of their arms and legs. So that at rest, you're probably not consuming as much energy as you would if the limbs were not paralyzed. The difficulty is really trying to estimate for each individual what your resting metabolic rate is and what the ideal body weight should be. We do our best to sort of knock down numbers from the general population, but these are all estimates in general. We know that increase in weight affects the fit of equipment as well as general mobility, for instance, transfers, and we know that it's more difficult to lose weight once it's been gained. So this brings us to the question of physical fitness and how it can be achieved. We know that physical activity represents almost a third of our total daily expenditure, and that there are many benefits to exercise that have been well documented, including in our lipid profile, reduction in the incidence of diabetes, increasing lean muscle mass, which in turn enhances fat metabolism, and improvement in depression and quality of life. We look to the CDC and the American College of Sports Medicine to provide recommendations on exercise for the general population. And they have most recently stipulated that 30 minutes or more of moderate intensity exercise most all of the days of the week is what's recommended. So what does this mean for the population with spinal cord injury? Generally, the recommendation remains 3 to 5 sessions per week of 20 to 60 minutes duration per session of moderate intensity exercise. And this is defined as 50 to 80% of the peak heart rate. So this is a tricky issue because we don't really know what the peak heart rate should be for each individual. For individuals with high-level injuries where they may not have as good regulation of their heart function, the peak heart rate might be artificially lower. It may not permit that level of autonomic reaction. Generally, in the general population, it is estimated at 220 minus your age as being the peak heart rate. This can also be assessed in some ways through actual exercise tolerance testing. What's interesting is that the ACSM, which published guidelines for exercise in the general population, also actually stipulated recommendations for exercise in those with spinal cord injury. And they recommend the use of different modes of cardiopulmonary training, including arm crank ergometry, wheelchair propulsion, swimming, wheelchair sports, walking with devices, seated aerobics, and electrical stimulation. The idea, though, is that we need to improve fitness without really increasing your risk for injury. And that's a fine balance sometimes to achieve. So what we recommend is looking at basic issues. For instance, cushioning, interfaces, making sure that you don't break down in the process of transferring to an exercise bench or an incline. I've had patients who've come to me with sacral breakdown because they've been using regular pieces of equipment in a gym without adequate support. Avoiding overuse, which may not always be the easiest thing to accomplish, by trying to exercise different muscle groups if that's possible, and limiting the amount of repetitions of that muscle group in exercise, or limiting the amount of resistance might be wise as well. Appropriate positioning to avoid falls or fracture, particularly if you're using gym equipment that's intended for the general population that you can't wheel your wheelchair up to, is important. And falls can occur either because of loss of truncal balance or even from spasticity throwing you out of position. Appropriate assistance will usually be required for positioning and setup. There are, just so you know, certain levels of certification for fitness trainers, including the ACSM NICPAD Certified Inclusive Fitness Trainer, or CIFT, which actually provides an additional level of training for certain trainers in physiology, exercise testing, and programming for individuals with disability, and includes instruction on inclusive fitness facility design, and ADA standards. Having said this, I have yet to meet a trainer who is SIFT certified in Western Washington. So if any of you know of any, please let me know. So strategies to reduce cardiovascular risk and spinal cord injury might include the following. Really, ideally, we're performing very targeted and detailed surveillance for modifiable risk factors associated with heart disease. So that includes looking at blood pressure, looking at cholesterol profiles, glucose tolerance or serum blood sugars, diet and weight management assessment, looking at tobacco use, activity level, alcohol use, and medications that might be contributing to cardiovascular risk. The bottom line for this and all of our recommendations is that all of these treatments have to be individualized for you. Moving on to the musculoskeletal system, many individuals, particularly those who are manual wheelchair users, have experienced upper limb pain, particularly shoulder dysfunction. And certainly anytime we're using a limb in a manner that it wasn't originally intended and creating a lot of force and overuse puts the system at risk for overuse syndromes, and we'll discuss that in a little bit more detail. It also puts individuals at risk for early degenerative changes or early arthritic changes. Spinal cord injury is also associated with bone loss in virtually all individuals with spinal cord injury, and this is particularly true for women with spinal cord injury because of the postmenopausal and hormonal effects of aging. So the unique physical stresses and demands of adapting to spinal cord injury can contribute to upper limb pain. And we believe that at least 50% of those surviving spinal cord injury are living with upper limb pain of some kind. Those who are more likely to experience this at greater intensity and severity are those actually who have higher levels and longer durations of spinal cord injury and who suffer them at advanced ages. Shoulder pain is far more common than wrist pain, and activities that appear to contribute to this dysfunction include transfers, wheelchair pushing, and pressure releases. Any activities that also require sustained overhead above shoulder raising of the arms can also contribute to upper extremity dysfunction, as will crutch walking in individuals with incomplete spinal cord injuries who are still walking. We know and we hear quite a bit about bone loss in the non-spinal cord injured population, and despite knowing a lot about it, we don't really have a general consensus on the best way to treat it in the general population. And this is definitely true in the spinal cord injured population as well. There are many risk factors for bone loss, which ultimately we're concerned about because it increases the risk for fractures. And we know that this increases with a longer duration of spinal cord injury. We believe that bone loss occurs immediately following the onset of the spinal cord injury and continues probably for at least 12 to 16 months, and then may achieve a new balance of bony resorption and formation. As providers, we always try and look at modifiable risk factors such as caffeine intake, tobacco use, alcohol use, and nutritional factors such as calcium intake and vitamin D levels. I won't go into a whole lot of detail about the issue of osteoporosis and bone health because there's a separate forum that was given related to bone health, and I would refer you to the website to review that issue in more detail. Individuals with spinal cord injury can also be at risk not only for contractures or loss of flexibility, but for back pain or neck pain at the site where they had fusion. So my suggestions for considerations and recommendations related to preserving musculoskeletal health are really primarily in the area of education and prevention. We've always heard this adage, to use it or lose it. And I think we're learning a little bit more over time that we have to balance the idea of using it and losing it with the idea of conservation and preservation. That is, by the time we identify severe shoulder dysfunction, oftentimes it's a little too far ahead of the game for us to be able to do a whole lot about it to reverse the functional losses that are associated with it. So a lot of it is really trying to balance becoming as independent as you can, but preserving that function for the long term. We also recommend that you be aware of the risk for fractures for your particular case and what symptoms can present that may not seem like fractures. So for instance, minimal trauma or no trauma, even just range of motion in some individuals can actually result in fractures in someone whose bone density is very low. And oftentimes you will notice swelling, bruising, warmth of the extremity that's fractured and not necessarily a bony deformity. So you have to have a high level of suspicion for having a fracture and to getting it treated appropriately. There are also special considerations for fracture treatment in someone who has a spinal cord injury that differ from that in the non-spinal cord injured population. And so it's also definitely worthwhile to have a rehab physician who's really well versed in the management of fractures after spinal cord injury involved in your care. Depending on the level of injury, there are different situations that can cause shoulder dysfunction. They usually result in imbalances in how the shoulder functions. Either we're overdeveloping the front part of the shoulder, not developing the back, or the reverse. Ultimately, we recommend that you have an assessment by your rehab physician as to what type of a shoulder program would be best for you and your therapist to employ to really maximize your ability to use that shoulder safely for the long term. There have been controversies about the role of shoulder surgery in those who are noted to have rotator cuff tears or acromioclavicular joint dysfunction or even arthritic problems of the shoulder. And although that decision also needs to be an individual decision based on what you believe the outcomes will be from that kind of intervention, one thing that you should be aware of is that the aftercare from shoulder surgery can be quite significant. There could be a very long period of rehabilitation that lasts months that may require additional help to be hired. It might require changing equipment temporarily and may result in some vocational issues as well. So planning for any type of surgical intervention would be crucial. What we also know is that the general treatment recommendations for the non-spinal cord injured patient do not necessarily work well for someone with a spinal cord injury. Telling someone that they need to rest the arm when they're a manual wheelchair user is not really realistic. And so usually the recommendation would be activity modification. Keeping up to date on osteoporosis management or seeking consultation from someone who specializes in osteoporosis care, particularly for individuals with spinal cord injury, is something that I really firmly believe in. Because this area of treatment is so controversial even in the general population, it is even more so among those with spinal cord injury. So moving on to the respiratory system. Everyone's still awake? Haven't lost anyone yet? Okay. So in the normal process of aging, we all lose a little bit of our respiratory function over time. There's a gradual age-related decline in our pulmonary capacity, and this involves loss of the elasticity of our lungs, decreased number of alveoli, which is the smallest unit of our respiratory tree, and we have reduced vital capacity, which is our ability to take a deep breath voluntarily, and possibly as we age, decreased respiratory drive. Respiratory disorders are important in spinal cord injury medicine because it's remains the leading cause of death and has been for the first year and chronically after spinal cord injury. All levels of individuals with spinal cord injury are at risk for respiratory dysfunction. Even though we all know that the diaphragm and the chest muscles are generally receive their nerve supply from higher in the spinal cord, usually around the neck area, we know that individuals with thoracic level lesions or sort of mid-trunk are at risk for respiratory dysfunction because it impairs the abdominal muscles which help with forceful expiration and cough to expel secretions. So really we consider individuals with all levels of spinal cord injury at risk. Spinal cord injury related respiratory dysfunction can take one of several different forms. It can be in the form of ventilatory failure, from reduction in the ability to take deep breaths, and we know that this is definitely aggravated by tobacco use. We know that individuals with spinal cord injury at higher risk for pneumonia due to poor secretion management, or atelectasis, where the lungs don't inflate fully, and for sleep-disordered breathing, or more commonly known as sleep apnea. There's increased vulnerability in the spinal cord injured survivors for complications from pneumonia, with 15% of deaths in spinal cord injury as opposed to 2.7% in the general population. In fact, those with tetraplegia are at considerably higher risk for dying related to pneumonia than those matched for age and sex who do not have spinal cord injury. And as we mentioned earlier, even what appears to be a benign respiratory infection can quickly progress into something pretty fulminating and require hospitalization for individuals with spinal cord injury. There are different forms of pneumonia that we worry about. There are pneumonias that are related to difficulty with swallowing, and this usually happens earlier after spinal cord injury, but can happen with any other disease process that impairs swallow, even an individual who's chronically living after spinal cord injury. There's also the emergence of ventilator-associated pneumonias, which is a primary focus of prevention in the acute medical world. As we utilize more and more equipment, we're realizing that we are also increasing the likelihood that there are bacterial infections related to the use of this equipment. And lastly, there's the most commonly acquired, community-acquired pneumonias or viral pneumonias, and that's why we're usually very insistent on recommending pneumococcal vaccinations every 5 to 10 years and yearly influenza vaccinations unless there's a strong contraindication. And one final word about sleep apnea or sleep-disordered breathing, which can occur in a not insignificant number of individuals with spinal cord injury, particularly those with tetraplegia or quadriplegia, and usually takes the form of obstructive sleep apnea, where the soft part of your palate, upper part of your airway might collapse down when you're asleep, as opposed to the central sleep apnea, where the respiratory drive is impaired. The consequences are well known. You can usually associate this with daytime sleepiness, which can increase the rate of motor vehicle crashes. There are cardiovascular complications from having chronic sleep apnea. And there are other consequences on rehabilitation efforts and wound healing. So suggestions and considerations for managing your respiratory system in the face of spinal cord injury include really maximizing and optimizing your ability to manage your secretions well, either through learning a variety of different ways to augment breaths, or utilizing secretion management strategies of different kinds on a regular basis, particularly in the setting of any respiratory disease. Vaccination as a means of primary prevention is pretty critical, and constant assessment of those who are at risk for respiratory dysfunction, meaning individuals with quadriplegia, as they age in terms of their vital capacity and other pulmonary factors, will be really critical. Assessment for smoking habits is we usually incorporate that into our general assessment. And if we're hearing any warning signs that individuals are not ventilating very well, they're having more fatigue during the daytime with certain activities, or not performing their transfers as well, not able to participate in their daily life skills, we're really at that point considering sending individuals to a pulmonary specialist to have more specific pulmonary testing and assessment to see if any additional assisted ventilation or supplemental oxygen would be warranted. So some of the warning symptoms and signs to be aware of are unexplained shortness of breath, any rapid breathing, daytime drowsiness, any fluctuating alertness, any more dramatic positional changes and influences on breathing, and vital capacity that's dropping, particularly if it drops under 2 liters, are usually warning signs to us that there might be some impending respiratory failure. Okay. In terms of our gastrointestinal system, in the general population, we know well that there is a decline in the motility of our gut, particularly the lower part of our GI tract, which can result in constipation issues. In the spinal cord injured population, there is already this colonic motility issue, which can result in incomplete emptying or constipation. It can get aggravated with aging effects. There's also a higher risk of gallstone disease occurrence in individuals with levels of T10 and above. The highest risk for that occurring is generally felt to be in the first year. But just so you know, we don't often send people electively to have their gallbladder removed just with a diagnosis of asymptomatic gallstones. I think the only patient we've shared recently who had that was a commercial fisherman who was going to be at sea for long periods of time and may not have access to urgent medical care. So in the absence of other worrisome signs, we're not usually sending people for elective surgical removal. Suggestions to mitigate the effects of aging on the bowel program are to really go back to basics and evaluate how you're doing your bowel program. It's not uncommon that I'll receive a request to see a patient semi-urgently in clinic because they're having a lot of difficulty with either bowel incontinence or abdominal distension or new onset constipation, and it's very distressing to these individuals. And at that point, we really reevaluate the basic aspects of their bowel program. Are they taking adequate amounts of fluid in? Are they taking proper diet in? Do they have the usual level of physical activity that they had previously? And particularly because bowel programs are fairly laborious and time-consuming, it's not uncommon that people will try and do this as infrequently as they have to during the course of the week. And although that might be a good plan early on, it's probably in your best interest to maintain a daily to every other day bowel program if possible to, again, minimize the effects of aging as time goes on. Hemorrhoidal treatment is usually achieved through topical treatment. It's pretty rare that we have to send an individual to a colorectal surgeon for surgical treatment of hemorrhoids, but in rare cases where it's refractory or quite severe, then we do have to do that. In terms of preventive health for colorectal cancer screening, we believe that the research has shown that the rate of an incidence of colorectal cancers in those with spinal cord injury really approximates that in the general population. So there's not necessarily a need to screen early. Having said that, however, there is the likelihood that we can miss early detection or appropriate detection of these cancers because many of the early warning signs can occur commonly, such as the presence of blood in stool, can occur commonly in the course of your bowel program and can result in a missed opportunity to diagnose this early. In terms of urinary tract management, the general population as they age experiences a reduction in storage capacity, so we're usually going to the bathroom a lot more frequently. In women in particular, there's reduced urethral competence, which can result in incontinence. And there's increase in involuntary bladder contraction, so that urge to go. There may be increased residual bladder volumes even after voiding, and this is particularly true in men as with the onset of prostate disease. After about the age of 40 or 50, there is a progressive decline in kidney function, and this may be exacerbated in someone who already has pre-existing kidney dysfunction due to urinary tract issues. Among those who are over the age of 60, there is an increased risk for urinary tract infections even in the general population. In the spinal cord injured population, we know that there's a higher risk for urinary tract infections and stones, and this can exacerbate the already aging kidney and the loss of kidney function, which is why we're usually pretty insistent on upper urinary tract surveillance on an annual basis. Depending on the type of bladder dynamics issues that you might have after your spinal cord injury, there could be either a high pressure system or a low pressure system. We tend to worry more about high pressures inside the urinary tract because this can ultimately get transmitted into the upper tracts or the kidneys and result in kidney dysfunction in the long term. Although previously the leading cause of death after spinal cord injury, genitourinary complications are now only represent 2.3% of the deaths in this population. There is, however, for those who are using chronic indwelling or Foley catheters, a slightly increased risk of bladder cancer in this population, particularly among smokers. There is likely no increased risk for prostate cancer, although there is that theoretical risk. It has not been observed at this time. So suggestions. First is to be aware that if you are older and have a spinal cord injury, that urinary tract infection symptoms can present differently than it did when an individual is younger. That is to say that individuals can be quite confused and lethargic as their primary symptom presentation rather than the urinary changes we expect. We know that blood in the urine is a very common occurrence in individuals with, who either catheterize themselves or have indwelling catheters. And so relying on blood in the urine as the sole means of assessing for bladder cancer or detecting bladder cancer is really not very reliable. Our goal when we're evaluating the bladder program on a yearly basis is to minimize the frequency of urinary tract infections. And although there's no general consensus on how many there should be in a year's time, in clinic, if we're hearing that people have more than 3 or 4 bladder infections in a year, we're really starting to evaluate why that is. Even if someone, for instance, has 3 to 4 on average a year, if the rate of urinary tract infections is increasing as the years go by, then we're really getting pretty excited at evaluating your urinary tract and your method of catheterization. We know that preventative or prophylactic antibiotics on a consistent basis to prevent the onset of infections is usually not indicated except in rare circumstances and probably just contributes to the creation of more resistant bacterial organisms. For those who are living with more than about 8 to 10 years with a chronic indwelling Foley catheter, we would recommend cystoscopic evaluation, and that's where the urologist puts a tube in through the urethra into the bladder to take a look around and see if there are any lesions in the wall of the bladder that are suspicious for bladder cancer. In general, we recommend being vigilant about avoiding overfilling of a leg bag that might cause distension of the bladder and transmit that back up to the kidneys in terms of pressure and backflow. We encourage women to continue using the smallest possible catheter size and trying to avoid increasing the size of the catheter to prevent more and more urethral incontinence. We advise smoking cessation, and we advise yearly upper urinary tract survey for stones and upper tract deterioration. And so that usually is comprised of 2 things. We need to get a picture of the kidneys, and we need to see how it functions. So taking a picture of the kidneys will tell us if there are stones or if there's any swelling of the kidneys, but it doesn't tell us a lot about how it's functioning. So it's really pretty critical that not only there be an ultrasound or a CT scan of the kidney, but there also be some assessment of how the kidney is functioning, either through lab tests or urine collection. So nervous system effects. We know that there are reported decreases in strength, reaction time, vibratory sensation, fine motor function, agility, despite what this picture shows, loss of muscle mass, detendon reflexes, and impaired walking and balance with aging. Individuals with spinal cord injury in particular are also at risk for the onset of weakness and loss of coordination, but also in particular for certain peripheral entrapment neuropathies such as carpal tunnel syndrome or compression of the ulnar nerve either at the wrist or elbow. We believe that as much as 60% or more of individuals with paraplegia actually have entrapment neuropathies. In addition, when you come to our clinic, we're usually asking you about any changes to your neurologic function, specifically any loss of feeling, such as pain or temperature, any change in your motor strength in areas that where you typically have normal strength and sensory function, because we're looking specifically for symptoms that suggest formation of a cyst or a syrinx in the site of where you'd had trauma. And this is, although it's not entirely uncommon to develop a small cyst where the injury occurred, it's a little less common for this to extend beyond a certain level of injury. And because these cysts can sometimes expand either towards the head or down towards your feet, it can actually be a cause for late deterioration in function. So we're usually monitoring very carefully for any evidence of neurologic deterioration. And if you're to notice any, then you should let your rehab provider or primary care physician know as soon as possible. Nerve entrapment such as carpal tunnel syndrome can be treated with relative rest. Again, it's usually impossible to completely eliminate the use of the limb. We can try splinting, or in some cases really advise you to proceed directly to surgery in an attempt to spare as many of the nerve axons or nerve fibers as possible. So there are several types of different carpal tunnel releases you may have heard of. Some surgeons still perform the open procedure where there's a small incision made in the wrist to open up the carpal tunnel. But there are some surgeons who use more an endoscopic technique, which uses a small tube and a much smaller incision. And generally this is associated with fewer precautions in the long term. And so for many of our spinal cord injured patients, there's a preference, if the surgeon is experienced in doing endoscopic releases, to refer them to someone who specializes in that. One needs to be aware that there will be post-surgical activity restrictions whether or not you have the open or the endoscopic procedure that may result in the need for altered equipment or additional care during the time of the recovery. So for instance, a manual wheelchair user may be advised by the surgeon to avoid using that extremity for a certain number of weeks, which may require temporary use of power mobility. If we suspect syrinx or cavitation of the cord causing neurologic deterioration, usually your physician will order imaging studies in the form of an MRI to assess the extent to which this is affecting the spinal cord. However, the presence of this cyst in and of itself does not warrant surgical treatment, and it's up to the surgeon to make that determination with you as to when it's time to surgically intervene, because the surgical procedure itself can result in certain complications. What I've observed in the practice here is that oftentimes our surgeons are reluctant to decompress or intervene in the formation of the cyst unless there is actual motor loss beyond just sensory loss. Skin issues in the general population, there's associated with normal aging atrophy or loss of collagen fibers in the skin, which results in loss of elasticity. And as these skin layers thin, then this increases the risk for developing problems related to shear and pressure. In the spinal cord injured population, then, in addition to the immobility and moisture and spasticity effects, there are aging effects that compound the risk for development of pressure sores. And so we're usually pretty vigilant with helping you monitor for skin breakdown during this period of time. So there are certain, there's research that show that chronic ulcers really act in a different way than acute ulcers do. That is, that the treatment is not necessarily always the same. Acute ulcers, sometimes by withdrawing what might have been an inciting factor, can easily, and taking pressure off obviously, can easily heal that ulcer. But there are certain ulcers that develop changes in the wound bed itself that are analogous to developing sort of squamous cell cancer or particular changes that are semi-cancerous that actually prevent the sore from healing. And so in cases where there might be an ulcer that fails to heal with all of the conservative and usual measures, sometimes the plastic surgeons will go in and actually biopsy or remove part of that, the ulcer bed, to determine if there are any of those changes that are preventing the wound from healing. The same is true for potential infectious complications of skin breakdown that might be preventing the wound from healing. So if we see a non-healing wound, one has to ask oneself whether we're missing some underlying insidious infection that's keeping the wound bed from actually closing up. If sometimes the location of the ulcer will give us clues as to how the pressure sore developed, whether it's something that typically is acquired when someone is laying versus sitting versus transferring across surfaces. But we really need your input and insight as to how the pressure develops so that we can help you prevent it from worsening or causing more problems. Adequate nutrition is key. Those with adequate nutrition will likely not develop pressure sores in the absence of pressure. And if you do have a pressure sore, adequate nutrition is absolutely critical to healing the wound. Preventing excessive moisture of the area and following good hygiene, preventing or minimizing or eliminating tobacco use is very critical because of the effects of tobacco on circulation at the end organs, including skin, is really critical. So trying to close the loop here with looking at how all of these issues affect your need for therapy and equipment. We know that associated with aging is an increased risk for falls, and this is true whether or not you're using a wheelchair. Issues that may require a reevaluation of equipment or reevaluation of therapy needs would include not only any falls, but the loss of strength and endurance, any new weight management issues, any new skin issues, or upper limb dysfunction that's significant enough to affect your ability to perform pressure releases or transfers. So this is a time that signals us to reevaluate equipment and decide whether an alternative system is necessary. So for instance, manual wheelchair users may at some point need to progress to using power mobility or power assist wheels to aid in their mobility and preserve their upper extremity function. Those who are ambulatory may actually choose to use a wheelchair as their primary means of mobility if this helps preserve upper limb function. This is also a good time to evaluate all of your equipment, including bathroom and ADL equipment, your seating system and other cushion and other interfaces such as your mattress, and to look at your transfer technique and equipment. Often therapy interventions would look at shoulder protection and conservation strategies. They may look at energy conservation or work simplification strategies for those who have considerable fatigue. We'll look at fall prevention issues and the adequacy of pressure releases and transfers. The idea really being that PT and OT evaluation is absolutely needed as each need evolves related to mobility and your health, and that this assessment needs to be individualized. There's really not a one-size-fits-all type of therapy treatment. It needs to be geared towards your particular needs. A quick word about women's health issues, because women have special health care needs. Women are more likely to be injured at an older age, and they have unique health maintenance and screening needs because of issues related to reproductive health and hormonal changes. But we also know that women experience pain differently than men do, and this is certainly true after spinal cord injury as well. Women, as we mentioned earlier, are at greater risk for osteoporosis. We actually believe that women approach fracture threshold in their bone mineral density faster than men do after spinal cord injury, and of course are at secondary risk for greater osteoporosis and bone loss as they approach menopause. Transportation issues are frequently cited by women in surveys of health maintenance as one of the greatest barriers to the ability to reintegrate into the community, to participate in exercise as well in the community. So at this point, you're probably tired of hearing me talk about all the organ systems. I'd like to turn the discussion over to the psychosocial impact of aging with spinal cord injury to Dr. Ivan Molton.
Thank you. Okay, hi everyone. I'm Ivan Molton. I'm a clinical psychologist here at the U, and Dr. Reyes presented a lot of the hard science of the issues of aging with physical disability. I'm going to be presenting a lot of soft science, or sort of fluffy psychological science, so bear with me. And also because in the interest of time, this might have to be a bit of a jet tour. I may have to go through some of these fairly quickly.
Can you give us a little therapy?
Absolutely. Hey, let's do it. 5-minute therapy, Dr. Phil style. Yeah. So I think I can say this very generally. Of course, everyone is getting older. We know the population is aging, as Dr. Reyes mentioned some of this. Just to show you some fancy pictures here, this top line is the percentage of the U.S. population that is over 65. And as you can see right now, it's at about 12.5%. But by 2030, it's going to be about 20%. That's 71 million people. So there is everyone's panicking, frankly, in terms of the healthcare industry, in terms of dealing with this older population. And of course, people who have physical disabilities are living longer. Here's one example. If you had a spinal cord injury in 1940, your life expectancy was about 18 months. And as Rina mentioned, in 2005, your average life expectancy is between 70 and 85% of normal with an incomplete injury. So in the past 50 years, survival for people with spinal cord injury has increased 2,000% as compared to only 30% for everybody else. So through medical advances, people are living longer in general, which means they're going to have more disability, and people with pre-existing disabilities are living much longer than they would have ordinarily. So we have this increased prevalence. And in the sake of time, I'll skip this, but well, this is life expectancy. If you didn't have a spinal cord injury, that's the top line. And if you do have a spinal cord injury, that's the bottom line over time. And you can see how the lines are about to cross here. Okay, so we're talking about aging, and in the psychological literature, we refer to this as sort of older adult or geropsychology. But to define the term older is tricky. Generally, clinicians and researchers talk about being older in these sort of bands based on sort of what are the challenges around certain ages. When we talk about people being middle-aged, the young old, the middle old, and the oldest old. And these terms are not meant to be derogatory in any way. I apologize if people fall into these bands. We talk about middle-aged. This is the one that usually gets me in trouble, lumping 45 and 60-year-olds together. But around this age, we see people struggling with work productivity. This is a career peak period for most folks. Planning for retirement really begins in earnest around here. Often raising teenagers, caretaking for parents, divorce, early health problems. This is a really stressful period. And actually, we'll talk a little bit later, this is actually a period that's associated with more depression than much older adulthood. Then you have the young older adults, 60 to 70, thereabouts. And sometimes you get the empty nest syndrome here. You typically are retiring, which seems to be harder on men than on women in the literature. But that usually means some financial pressures and some chronic health conditions, even in non-disabled folks, are starting to really take shape around this age. The middle old, 70 to 80. So now what's happening is the demographics start to change. And frankly, the men are dying off around this age. Women have longer life expectancy. And the demographic shifts pretty dramatically towards women. And I'm not going to say that's a good or a bad thing, but that's what it is. This leads to a lot of bereavement. You know, people are starting to die of natural causes around this age. But for those who are behind, there's a more serious threat of mortality, decline in physical functioning, and what really seems to panic people around this age is this threat of cognitive decline, you know, dementia, Alzheimer's. That's what people worry about or report worrying about in this age band. And then if you're very lucky, you get to be one of the oldest old, 80 plus. My grandmother just turned 96, which is pretty incredible. But some of the challenges associated with being 96, social isolation is a big one. You know, her best friends she met in the Second World War in London. You know, most of them are gone. Serious limitations to independence. Cognitive decline is pretty universal at this age, even if you don't have a dementia per se, even if you don't have Alzheimer's. Yeah, memory, concentration are not what they used to be. And chances are you may not live very long, some health problems coming along. So a lot of challenges associated with aging. So the question is, do we think that these older adults, as a general category, are more likely to be depressed or to have severe depression than our younger people? And I'm curious, who can give me an estimate of what percentage of people over 65 do you think cope with a major depression, a significant depression? 12%. 12%. Good guess. Anybody else? 16%. Okay. So actually it's lower. It's between 1 and 3% of people over 65 meet criteria for major depression. Now, there's some controversy about this number because we also know that older folks are less likely to report depression or depressive symptoms, but that's what people are telling us. And the times when major depression, significant depression, peaks in the non-disabled population are in the adolescent years, those tumultuous years, and then your early 20s. And then there's another spike around middle age, probably for the reasons we talked about. But generally speaking, and this has been shown in hundreds of studies, older adults, and I'm calling those to people over 65, no offense, report better psychological adjustment pretty much across the board than do other age groups. Even people with physical disabilities like spinal cord injury. Most older adults do not struggle with significant depression. That's not to say it's not out there, and it's not to say it's not important, and especially in a person with a physical disability, it has dramatic implications, but it's not common. So, since the purpose here is to talk about aging with spinal cord injury, as Dr. Reyes discussed, aging with SCI generally means more physical limitations, right? And requires some changes in caregiving, generally. Greater use of adaptive technologies, and that's a change. You might have to switch from a manual to an electric wheelchair. You might have to move into more adaptive computer equipment. And also the learning of new skills, new transfer techniques, new positioning, that kind of thing. So again, one wonders, are older adults with spinal cord injury more likely to be depressed given that? And the answer, surprisingly, from the literature is no. One huge study of aging with spinal cord injury done in Great Britain showed no significant differences in life satisfaction or psychological well-being between either older and younger adults with spinal cord injury, right? Or between older adults with and without spinal cord injury. So even though the older adults with spinal cord injury reported more physical limitations, more financial strains, less independence, their emotional well-being was as high as their well peers, which is an interesting phenomenon that no one quite understands just yet. But it seems to be that older adults in general make better use of certain coping strategies for managing things like pain and disability than do younger people. And this is probably, in general, about having a lifetime of experience in coping with stressors. When it comes to spinal cord injury, some of my clients that I work with spinal cord injury say, I have to adapt to a whole new lifestyle every 3 to 5 years. There's a lot of chronic adaptation, which over a lifetime leads one to some pretty good coping, generally, some pretty good flexible coping. Also, what seems to happen with people with spinal cord injury in particular is that there is this shift towards what we call acceptance coping, which I think is a misnomer. It doesn't mean you give up on making things better. It doesn't mean you stop trying to improve things. But there's more acceptance of physical disability as people get older, which I think is useful for people who are really experiencing a lot of physical impairments with spinal cord injury. But again, regardless of spinal cord injury, neuromuscular disease, aging, from the literature on this, the biggest predictors of quality of life are the things we would expect them to be. Activity, perception of being productive, having family, having friends, having activities that you enjoy, right? And these are all things that we don't see big differences in terms of spinal cord injured and non-spinal cord injured folks. The limitations are there, the physical limitations, but the emotional well-being isn't as different as one would expect it to be. But there are factors that really do impact the effects of spinal cord injury. Age at injury is a big one. So what we seem to see here is that at what point in your life did you acquire the disability? Acquiring a disability very early, by very early I mean 16, 18, 20, is actually associated with a pretty good adjustment to disability over the lifespan. And likewise, if you acquiring a disability later in life, 65, 70, is associated with pretty good adjustment. The time you don't want to get hit with a disability is when you are most thinking of yourself as a non-disabled person, say 40, and you are struggling the most in terms of raising kids, financial stressors, career peak, these kind of issues. So age at onset of disability is an important factor. And your current age is an important factor, again, because it depends on what stressors do you have. The stress of retirement is hard enough for the non-disabled population. So having to retire early due to physical disability is a whole unique set of stressors. And then number of years with injury seems to be a very important variable too, and it seems to be, again, kind of a proxy for coping experiences. What works, what doesn't work, right? So the longer you have the injury, typically the better your psychological adaptation is to the injury. Up to about 30 years. For whatever reason, the science sort of shows that at about 30 years you've learned all you're going to learn from your disability. And at that point, people kind of plateau. So I've been talking about these positive things, right, that generally older adults with spinal cord injury do quite well. But that's not to say there aren't challenges and problems. So as a person is aging with a spinal cord injury and their physical independence is decreasing, their social support network is also getting older. This is the biggest issue that older people with spinal cord injury report to us is, hey, it's you know, my body is becoming more challenging and harder to manage, but at the same time, my friends are getting older. My friends who used to be able to give me a hand on the stairs now have low back pain. My friends who used to take me out into the park now have to stay at home with fibromyalgia flare-ups. I mean, so your peer network is becoming sicker and older as well. And generally, unless one is very lucky, finances tend to get tighter in later adulthood, unless somebody has been really an exceptionally good planner with retirement, and especially in this climate, right? So these are the challenges. These are basically the same problems as for older adults without a spinal cord injury, but they're certainly more dramatic. The implications are more severe, especially as one has to make a shift from using one's friends as a network of support to having to pay professional caregivers to be the network of support. That's a tricky psychological transition for a lot of people. So when we ask older people with spinal cord injury to describe their concerns, here's what they talk about. Uncertainty about the future, primarily physical and medical uncertainty. A lot of folks, this is interesting, we just did some focus groups actually with older adults with spinal cord injury, and they told us something we didn't even think of, which is, my doctor is getting old. I'm going to have to transfer my care from my doctor, who I've had a relationship with for 20 years, to someone new. There's a lot of uncertainty about that. Uncertainty about the degree of physical decline and how fast it's going to happen. Uncertainty about the costs associated with the physical decline. And tied to most of this is a fear of losing one's independence. And this is really a very big source of anxiety for older adults in general. But whereas most of the older population says, I'm really scared I'll get dementia and lose my independence, the older spinal cord injured population says, I worry my symptoms will become worse and I won't be able to be functionally independent. Pain is a big one. Pain and fatigue are the two symptoms that really start to ramp up in older adults with spinal cord injury. And that increasing physical pain can lead to depression and other kinds of negative affect, anxiety. And sometimes social isolation and loneliness are a factor. This isn't as big a factor as people think. There's been some really startling surveys where they interview younger people about, you know, what percentage of older people do you think are really socially isolated and alone? And they're like, you know, oh, 85%, you know, 90%. And then you ask these older adults, and they report rates more like 5, 10, 15%, right? Most older adults are not socially isolated and desperate for conversation. But with spinal cord injury, this can become much trickier as a person starts to isolate more because they physically can't get out of the house as much, right? As their friends become sicker and older and can't visit as much. So older adults with spinal cord injury, I think, are at greater risk for social isolation and some of that loneliness. So these are just some general, this is my Dr. Phil for you here. These are my 3 or 4 giant tips for trying to stay psychologically healthy as you age with spinal cord injury. The biggest thing that we see from the literature is just to stay socially connected. This can be very challenging, and it requires effort, especially as one's network, one's peer network is aging and people are dying, as people are moving, as people are retiring to Florida. You have to be conscious of how much peer contact you're getting. Staying physically active is huge. This is a big, big predictor of depression. And of course, that's within a person's ability and physical limits, and it depends on the level of your injury and all those factors. But getting out into the community is a really important way to increase well-being. And exercise, which, you know, again, depends on your condition. That could be physical therapy, just range of motion. I work with one guy who's really into yoga and Tai Chi. Or just any maintenance exercise program will be good. And then staying engaged in pleasurable activities. I think spinal cord injury in general can be so much work, and as you age with spinal cord injury, it can feel like more and more work, and people sometimes forget that you got to have some fun in there too, and that it's not just going to happen. You have to build it in. You have to actually find ways to put pleasurable activities into your schedule. So don't stop doing whatever it is that you like to do as you age. And then knowing when to ask for help, who to ask for help, and I would put on here also how to ask for help. This is tough because most people who've had a spinal cord injury for a long time have sort of this fighting spirit about it. You've coped with symptoms for 20 years, 25 years, 40 years, and suddenly you have to make this transition into asking for more help. And it can be a very difficult thing for people to do. And in general, we want people to be as independent as possible. So when a 40-year-old person with spinal cord injury comes to me, I might be concerned that they're asking for too much help, right? We want people to be independent. But in older age, at 75, at 80, a person has to become more comfortable with asking for help, knowing who's going to provide that help, who can give you emotional support, who can give you tangible support, and knowing how to ask in a way that makes you still feel empowered, which is a trick. So just some closing remarks, and then I'll hand it back over to Dr. Reyes, I guess in the interest of time. It's surprising, I think, to most psychologists and researchers in this field to see that as people with age with spinal cord injury, their physical function continues to decrease, but their psychological and emotional being typically does not. And that is generally true for people who maintain social contacts, activities that they enjoy, and physical activity. So, yeah, I guess the take-home message would be to try to stay connected as much as possible as a person aged with spinal cord injury. Thank you. Any questions before I hand it over? It's kind of a whirlwind tour. Okay.
In the interest of time, we're going to wrap up actually and open this up for questions and answers if you have any. Again, I think hopefully the benefit of this talk is not to depress all of you about the issue of aging, but really to provide some information to help you make decisions on how to live a healthy life for the rest of your life. So, any questions from the audience? So the question was, children who are injured with spinal cord injury, are they at any risk for particular premature aging? Okay. So generally they're at risk for the same types of issues that adults are. The issues that come up relate to equipment, schooling and vocational issues, and the young girls who have spinal cord injury in particular, we believe go through the same reproductive health issues as do their counterparts who are injured at an older age. So there are some specific medical entities that are more common in individuals who are injured at younger ages. For instance, there's a higher risk for developing high serum calcium levels in the pediatric age group, but that's usually fairly self-limited and doesn't affect their overall outcome. It's fairly easily treated. So most of the focus on what's unique in pediatric spinal cord injury has to do with just making sure that their equipment in their different growth stages grows with them, and that their adaptation, and maybe Ivan can talk about that a little bit more, is addressed, particularly with regard to school and community integration issues.
So I can't speak generally in the world, but the University of Washington does have a rehab psychology outpatient program with counselors and therapists who are trained in disability, spinal cord injury, neuromuscular disease, brain injury, that kind of thing. Yeah.
So the comment was that there are definitely genetic effects on not only longevity but on how you live your life, really. And so there definitely is literature to support that that's a primary contributing factor to longevity. There is literature as well to suggest that there are some modifiable risk factors that affect your overall longevity as well. So I think they do go hand in hand. But you're right, it's hard to overcome genetics in any disease process.
And the positive side of that is it's great you've had good role models for aging well, right? For aging with sort of dignity and independence. Yeah.
Yes. So the question is, how many other consultants should be involved, and how should you make that happen to really integrate your care better? And I think that's a real limitation in our current healthcare system, that there's so much fragmentation in the care. Definitely, if you have a spinal cord injury, I'd strongly recommend that you have a rehab physician who's familiar with spinal cord injury involved in your care to look at all the different life transitions and the implications of that. Because rehab physicians cannot possibly keep up with the volume of primary care literature out there, I really strongly advise that there be a primary care physician as well. Maybe not as critical in the younger years, but it certainly, as you age and require all the usual healthcare maintenance, cancer screening, all of that needs really a primary care physician to help manage all those aspects. Quite frequently you're needing a urologist not necessarily every year, but depending on the bladder issues and urinary tract issues, you might need a urologist involved who's also familiar with spinal cord injury. That's sort of a critical piece there. You may or may not need a neurosurgeon, depending, or orthopedic surgeon, depending on what type of fusion you've had and how frequently they want to follow you earlier on. So those are probably the most critical pieces. For individuals who have higher level injuries, the involvement of a pulmonary physician might be required as well. As far as who coordinates all that, we're usually trying to help coordinate that on the rehab end and making sure that that happens. If we're not following a patient very frequently, then it might fall on the primary care physician to make sure that all the consultants are involved. But we're usually trying to help in that process.
I think it is true that just in my experience in talking with people that often around an injury in childhood there's so much going on physically. You're trying to get back physical recovery, you're trying to finish school, there's so much just going on in that period that it takes sometimes a quiet spot before some of the negative kind of emotions hit you. So there can be kind of a 10 to 15 year delay sometimes where you get through adolescence, puberty, graduating high school, getting as much physical independence back as you can, and then there's this point where you say, wow, what about the rest of my life? What about my goals? What about falling in love? What about getting a job? And that can spin people out a little bit. But